video is a comparison of the width of strokes between hand instruments and ultrasonic scalers. All hand instruments and ultrasonic scaler tips make a stroke that's virtually the same width. And this is because the curvature or the shape of the tooth is always either convex or concave. Regardless of the shape, the size, or the length of the blade of the instrument or the tip of the ultrasonic, it will hit the tooth on a tangent, and that's why the width of the stroke will be the same. So I'm going to illustrate this on a number of extracted teeth which have been painted with a black model paint. You can do this also with fingernail polish on an extracted tooth or on a typodont. So let's see what happens as I work on these extracted teeth. The purpose of this video is to illustrate the width of stroke of various hand instruments and some ultrasonic unit tips also. I've got a collection here, and you should also try to obtain some extracted teeth and paint them with either this black airplane model paint, or you can use fingernail polish. I'm going to move these away so I can hold this molar and show you how I'm going to use a Gracie 1112. Let me hold this as if it's in the mouth, and I'm going to fulcrum on my finger here and lay the 1112 blade against this tooth as if I'm scaling this mesial surface. So lay the blade in here, and then I'm going to make one good stroke, and you'll see about the width of a stroke. Let me do that again. The width of one stroke with something like a Gracie 1112. Even if I try to lay this against the tooth, it might hit in two spots like that, two places, but generally it only hits in one spot like this. A very small area of the blade will actually remove biofilm or calculus. So this is why when we do instrumentation, you need to do overlapping strokes like this. And generally you work from, when you're in a pocket, you're working from the midline or the middle of the tooth across to the opposite side. Like in this instance, it would be toward the lingual side. In order to remove the rest of the biofilm or calculus, you would have to turn an 1112 over, come into the pocket, then you start in the middle somewhere, and then you scale. I'm scaling from the lingual aspect, but I'm going toward the buccal, you see, and completing the buccal half of this. So you have to do overlapping strokes. Now, let's take a look at another tooth with a different instrument. Here's a close-up of a Gracie 1314, and I'm going to adapt it to the distal surface. Now, the 1314 seems like a big blade that curves around and hugs a lot of the tooth. This is what a 1314 blade will do. It does about that much with each stroke. So if I advance it and do another stroke, I run the risk of missing something in between. So once you're in a pocket or once you're scaling, you have to do overlapping strokes. Watch what I'm doing. Overlapping strokes, only moving forward about 1 millimeter at a time with each stroke. Even then, it's often common to miss areas in between strokes. Now, if we come in from the other side now with the 1314, we start right about in the middle. Even though you try to adapt the whole thing, only about the first millimeter of the blade is going to actually contact the curvature of the root. It is the curvature of the root, the anatomy of the root, that dictates how much is coming off with each stroke. So you have to carefully adapt this. It's basically a straight line with any kind of a bladed instrument. It's a straight line hitting a curved root that's either convex or concave. So the strokes have to be very carefully placed, progressing 1 millimeter at a time across the tooth surface, overlapping and very close together like that. Let's look at the width of stroke now with a mini 1112. This is half the Gracie blade length and thinner. And you'll see that when you go into a pocket, this is a shorter blade, so it adapts really well to the anatomy of the tooth. We'll adapt this in the pocket as if we're in a deep pocket, and let's do one stroke. See how tiny this width of stroke is, but it's the same as a Gracie, as a universal, as almost any hand instrument. Everything removes about the same width of stroke because it's the curvature of the tooth that's dictating what comes off. So we do overlapping strokes with this mini across the surface, and we run less risk of spanning across depressions or lacerating tissue as we go across toward this line angle. Let's flip it over. Once the mini is in the pocket, you see if you start here at the midline, because it's shorter, you can do overlapping 1mm strokes, just as you would with a larger Gracie or a larger universal, but it's very precise in its adaptation to the anatomy of the tooth. So even if it's half the blade length, it's very efficient in adapting to the tooth contours, and you get about the same width of action or the same blade width with a mini as you do with a regular Gracie or universal. Okay, I have an anterior tooth here, and I'm going to come in with a Gracie 5/6. You'll see how big this blade is on the proximal surface, and we'll lay it down and do one stroke. That's about what this does. Now, if I lay it really flat, let's see if we can get more of it to contact. Yes, it's hitting the contact, the height of contour here of the root, but the depressed, developmental depression part of the root, you see, is not contacted at all by this Gracie. So this is one of the disadvantages of scaling with a bigger blade, like a Gracie. This is a 5/6, or the 1/2 would be the same size. Even a small universal curette, or let's take an average size universal curette. This is a universal curette. It's going to do the same thing. It's just going to hit the high spots and not be able to negotiate the depression unless you back up, and you see then you're off the tooth. Unless you have really loose tissue, you're just not going to hit that area. So what do? Here's a micro mini. These are new instruments. They are 70% smaller than a Gracie and thinner. Here's the blade, and I'm going to adapt that, and you'll see what this is able to do. So with overlapping strokes with a micro mini, you can go this way, and I'm into the depression now. I'm going to flip this over and come from the other side and then adapt this to the depression in order to completely scale out the depression. So this is a very tiny, sharp blade that adapts very well to the contours of the tooth. I've got to get it really parallel though, so that it'll really go into this area. Okay, now the advantage of this instrument is really obvious for the anterior teeth especially, and for areas like furcations. But let's look at the lingual of this tooth, and you'll see on the lingual that if I get this micro mini, I can start on this lingual and do overlapping strokes, and it will remove calculus very carefully, you see, without impinging on the tissue. Also at the CEJ, you can do very, very short overlapping strokes, or you can do a bit of a horizontal stroke with the toe like this, right at the CEJ very carefully, and it will remove the calculus right at the CEJ. So something like this that's very small is important to adapt to the tooth. There's another instrument that I'll show you on the facial of this same extracted tooth, because all of these anteriors are very narrow. So there's an instrument called a Sub-Zero. It's a Gracie Curvette Sub-Zero. Several companies make this, and it adapts really well to these very narrow surfaces. So I'm on the facial here, and it's got an extreme curvature to it. So it's half a Gracie blade and thinner and curved. Very, very acutely curved around. And as I said, this is made by several different companies, but it's a really excellent instrument for anterior teeth. I'll go around and then do a proximal surface with this as well. This is the Sub-Zero, and you'll see how quickly this will adapt to the tooth. I'm going to come around from the other side with the Sub-Zero and then show you what we can do with this instrument. Very, very quick to adapt and very efficient in scaling line angles, linguals, facials, and proximal surfaces. Now here's another molar, and I'm going to illustrate how a universal curette will perform. I'm going to lay this universal curette blade on the tooth and see what the width of the stroke looks like with this. You see that it does about 1 millimeter width. Even if I lay it very, very close to the tooth, it hits the high spots, so it'll do 1 millimeter here, 1 millimeter there. And if I do overlapping strokes in the same spot, that's what's going to happen. So you're going to have to move this blade, and even if I move over here and try to do this whole thing, you see it's not going to cover everything. You've got to use the lower third of the blade and do overlapping strokes. This is a universal curette now to go across a surface. I'm going to flip it over. Then you have to come from the other side, and that stroke actually starts somewhere near the midline, and then you'll pick up the buccal half of that tooth or that mesial surface like that. Now, even if you do this, you see you can never remove 100% of the biofilm or the calculus. There's always some embedded areas, and we'll look at ultrasonics to see what the potential is for a stroke with the ultrasonic scaler. Now let's take a look at a tooth and a Nevi sickle. It's a curved posterior sickle, and we're going to stay fairly superficial here because you might use this under the tissue, but you will probably be on the crown of the tooth. And let's see what the width of stroke is with this instrument. So even though it's a gigantic or pretty big blade, you see that each stroke only removes, again, about 1 millimeter, starting at the midline of the tooth and then going toward the lingual surface. So again, it's a straight cutting edge hitting a curved surface. Let's flip this over and come around from the other side, and then we would start somewhere near the middle, and then again you have to do overlapping strokes over to the other side. So this is whether you're on the crown or on the root. Any blade, sickle, curette, Gracie, universal, they all are just going to hit the tooth on a tangent and remove a small amount. Ultrasonics do exactly the same thing. So we'll take a look at the ultrasonics in another segment next. Now let's look at the molar tooth again, and I'm going to come in now with a typical 10 tip with a magnetostrictive ultrasonic on maximum power here. And if we go down, you'll see that a downstroke with a magnetostrictive tip like this, if I go multiple times, I'll get about 1 millimeter, less than 1 millimeter wide stroke. You can barely see it. Okay, but typically we would go obliquely or horizontally with this. So I'm going to show you what an oblique stroke would do. It touches about that much. Okay, now let's go horizontally with this. I have to lean it in a little bit, but I don't want to lean it more than 15 degrees. But you see, even if I try to adapt this really a lot, it's only going to do about that much. Okay, so what this tells me is that if I try to adapt the whole tip, in other words, on a line angle here, adapt the whole tip, it's still only going to touch about that much. Let's try it on another surface here. If I try to use the whole thing, it's vibrating, but really the first millimeter or two of an ultrasonic is really the part that you're going to adapt that's going to contact the tooth. Why is it doing this? Because the root is curved. So no matter how hard you try to adapt this whole thing across, it's only going to touch on the high spots.
It'll only touch the high curvatures of the wherever you're scaling or touching. Okay, so that means that when you're on a surface like this, you have to go, and you start at the top. You have to go horizontally or obliquely, very short overlapping strokes down, and then you're going to go to another section, go down, overlapping strokes, and control this so that you're doing very careful overlapping strokes. Or you can do your overlapping strokes across at this level, say. I didn't get all of that. And then go down a little bit and go across again, and then go across again. Okay, so you can use a combination of sort of vertical strokes like this, very soft probing type strokes. You can use oblique strokes, or you can use horizontal strokes. And if you're doing calculus removal, you have to do this fairly slowly in order to break through the calculus. It's not going to blast it unless it's really crumbly new calculus. But if it's tenacious, you're going to have to hold this on there for a while. So the point of this exercise is to show you that no matter where you are, if you try to use the whole ultrasonic tip like this, it's not going to contact the tooth except in a very small area. So there's virtually no difference between the width of stroke of an ultrasonic and a hand instrument. Let me turn this now, and I'll turn it so that we'll do something similar to a hand instrumentation stroke. Let's go like this. Okay, width of stroke about the same because of the curvature of the tooth. It has nothing to do with the machine or the design of the curette or anything. So if you're going to do this type of a stroke, again, you have to do overlapping strokes. You're using a light touch. You don't have to put as much pressure on the blade as a hand instrument, but in terms of overlapping your strokes, you have to do exactly the same type of overlapping 1 millimeter strokes that you would do with a hand instrument. Now I'm going to use a slimline anterior straight slimline tip on medium-high power, and I'm going to show you what a vertical stroke will do going down. Okay, that's a very slim area. And then I'm going to go obliquely across the surface. Now, actually on a molar, you shouldn't be using this tip. I'm just using this for purposes of demonstrating what part of the tip adapts here. But we'll switch in a minute to a curved tip and look at that, the pattern of use there too. But I'm showing you this tip because a lot of people erroneously use this one everywhere in the mouth, and it's really more suited for anterior areas. Let's lay it on a line angle and show you that even at the line angle, only the first millimeter of this really removes anything. And this is because of the curvature of the root. If I go horizontally across here, even though I'm laying it, I'm laying this right on the crown here. And I'm going to go across like this. And you'll see that only the first 2 millimeters are really doing anything. It doesn't touch the rest of the tooth there to remove anything. So you'll get turbulence and removal of loose biofilm, but if the biofilm is old in the pocket and it's adherent, it's sticky, then you've really got to cover every square millimeter like this with overlapping strokes. You don't have to apply a lot of pressure because you don't need to scrape with a blade with an ultrasonic. You're going to use lighter pressure, but you still have to do overlapping strokes starting from the top, and then you work your way down like this, down the root. So you've got to go horizontally or obliquely. You could go obliquely like this, but you have to do overlapping strokes to cover every square millimeter of the tooth surface. Now, if you go to a buccal surface, let's go to the buccal here, and you do oblique strokes. Let's do some oblique strokes. You know what? I'm going to switch this right now to a curved tip. Now I've switched to a curved tip, and I'm going to do some oblique strokes here along the buckle. So you still have to do channels with this tip to go along the buckle. And then at the line angle, let me show you here on the distal line angle, that even if you adapt this again, the tip is going to remove about that much, so you're going to have to overlap your strokes. Better to start at the top and then work your way down. Okay, so here it is on the distal, like this. Okay, and if you come obliquely this way, for instance, if I were to come in from the lingual side with this and come obliquely with strokes, again, the tip only contacts a very small portion with each stroke. So again, you would overlap your strokes, keep them very close together like this, very precise as you come across a surface. So even with a curved tip, it still only contacts a very small portion. So remember, the first millimeter or two is active, and so there's virtually no difference between how much of the tooth this contacts and how much something like a Gracie or a Mini does. Now, some people would continue with that slim line. I would probably pick up a hand instrument like a Mini or a Micro Mini and then continue to do this and overlap my strokes and go over these areas where I started with the ultrasonic. I would flip that over and then do overlapping short strokes to pick up any residual deposits on the surface like this. So that's a matter of personal preference, how much you use the ultrasonic and how much you use hand instruments, but both of them cover about 1 millimeter or 1.5 millimeters to 2 millimeters in width of stroke. Now I'm going to demonstrate the width of stroke with a piezo ultrasonic. This is a large tip on higher power. This is a medium high power, and I'm going to adapt this to the mesial surface and do a horizontal stroke. You see the width of stroke there. I'm also going to do some vertical strokes here, go down, and you see that's a very small channel. But normally when we do vertical strokes like this, we're trying to break a ledge of calculus. We're not doing biofilm removal. Okay, so even if I try to adapt this really, really tightly against the tooth, only the first millimeter or so is going to touch like this. So it's very important to start at the top and do overlapping strokes about 1 millimeter in width and go down, or you can go across like this, 1 millimeter at a time, and then come across again 1 millimeter at a time. So even on a line angle, this type of piezo tip, you can't make the whole thing work. It's just going to contact the height of contour of the enamel and then the height of contour of the root. On the buckle, if you do oblique strokes across the buckle, it'll do something like that. Or if you do horizontal strokes across the buckle. That's very good on the enamel here, did quite a bit. But when you get down on the root, again, just the tip is going to sort of touch the high points, you see. So you have to be very, very careful in your adaptation with any kind of a piezo tip or magnetostrictive tip, and you're going to carefully go over every square millimeter of the surface. You don't have to apply a lot of pressure. Here we're keeping the lateral surface parallel to where we're working, and we're going to do very careful overlapping strokes. Here in the entrance to the furca, I probably would do some vertical strokes and just be very methodical in your strokes. So there's no free lunch here. There's no taking a piezo or a magnetostrictive and waving it around and getting everything off with a few strokes. It's not that different from hand instrumentation in the width of the stroke. so you have to do careful overlapping strokes like this. And the advantage of these ultrasonics is that I'm using a very light touch. I don't have to worry about sharpening a blade, and I don't have to worry about exact angulation or cutting blade angulation. Okay, so be very careful. Use overlapping strokes, light pressure.
Even after viewing these videos, many people remain skeptical. So I challenge you, whether you are a student or a practitioner or an instructor, do this exercise yourself on extracted teeth or on a periodontal typodont. Paint it with hobby paint or use fingernail polish. And then try your own instruments, hand instruments, and the ultrasonic scaler tips that you like to use on these extracted teeth or the typodont. It will teach you so much about instrumentation. So, now that you've seen this video, it gives you some background, and we're ready to move on to the lessons on periodontal instrumentation with bladed hand instruments.